Well, good afternoon, everyone. We are so excited to be here with you. I know this morning has been full of ways that we are reimagining health equity, and this panel is going to take us into a deeper conversation about rare kidney disease and some of the innovations that are happening to really change what it looks like for communities. How many of you have been impacted by kidney disease by a show of hands? Anyone that has had anyone in your life that's needed a transplant or a donor or dialysis or treatment in any way? Okay. How many of you work in kidney disease or treatment? Okay. So we're here with a panel that's really going to represent each one of those voices. We're going to hear from the patient perspective, the physician, the community, and even the patient advocacy org. I'm Shirea Thompson. I'm the founder and principal of the IRIS Collaborative, and I also am a proud advisory board member of the National Minority Quality Forum. So we're going to go ahead and get started, and each panelist is going to open up by sharing a bit about the work they do. I'm going to briefly tell you who they are and where they're from. So first we have Dr. Stacy Johnson, who is the Associate Medical Director of Clinical Development, at Veritex. Next, we have Reverend Lilo Miles, who's the Associate Pastor of Enon Tabernacle Baptist Church. Next, we have Ms. Sharon Rouse, who's the founder, Sharon Rouse, who's the Executive Director and founder of Kindness for Kidneys International, Inc. And right here, we have Ms. Melanie Harris, who's the Senior Director of Kidney Disease Education and Strategic Partnerships at the American Kidney Fund. So thank you all for joining us for this conversation this afternoon. We're going to get started with the first question. And I'd like to know, what role do you play in the effort to address inequities in genetic and other rare kidney disease? So that'll be your by way of introduction to the audience today. And we can just start here with Melanie.
So what I want having I think you just can't hear. I'll just do this. Fine.
Thank you.
Well, first I was wanting to thank having me here. I'm representing my colleague Mike Stigler, who's our VP, who's unable to be here. But I do want to start by saying at American Kidney Fund, it's a nonprofit organization, and we're a patient advocacy organization. And not only are we addressing health equities through our government relations that we're doing, but as an organization, we've always been focused on health equity. I know after the killing of George Floyd, it became at the forefront of a lot of different priorities. However, since our founding in 1971, we've always been focused on helping people who are low income. We've been focused on people who are most at risk for kidney disease, primarily Black populations all over the world, Latino populations and other groups. So what we did is really kind of shift what we were doing and how we were addressing health equity, especially in the rare disease space, and helping to bring awareness to the fact that a lot of people are never told what their diagnosis of kidney disease was. And there's a huge disparity in kidney disease among Black people, among people who are Latino. Black people are almost 4 times as likely to go into kidney failure than white people with kidney disease, less likely to receive a transplant, and also not very likely to receive a confirmed diagnosis of their kidney disease. So through our partnerships that we have with various organizations, great sponsors that we have, such as Travere, such as Vertex, AstraZeneca, I mean, we have a lot of different support for what we're doing, and also in the community to address those inequities with people being diagnosed too late, not being aware of genetic causes of kidney disease, or that they are living with a rare type of condition and that there are treatments available that may not be something that's been a priority in their treatment with their physicians, and also just humanizing people. I mean, people are people before they're patients. And for us, it's very important that we recognize the humanity of people living with kidney disease. People are not a statistic. They're just not filling up a dialysis chair. They're people. So that's really what we try to emphasize at American Kidney Fund.
Thank you. I love that people first approach. So Sharon, I know you have a personal journey as well. So can you share a little bit about your background?
Sure. Am I on? Oh, good. Okay, so my name is Sharon Rouse. Thank you so much for this opportunity. I am the founder of Kindness for Kidneys International. We were founded in 2018. And so in 2006, I woke up to go to work, and I woke up with swollen legs, and I didn't know what was going on. I felt okay. I was tired. I was a new mom. I had a 5-month-old, but I was a school counselor. And so I thought, oh, well, I feel okay. I'll figure out what's going on later on. And so I went to work and decided to go to the school nurse and just say, hey, you know, what do you think is happening here? I have these swollen legs. I woke up this morning. I'm a little tired, but I have a 5-month-old. I'm just getting back to work. So I'm thinking it's normal. And so he said, you know, no, you need to go to the emergency room right now. And I'm thinking to myself, why? You know, I have work to do today. That was my mindset. And for those who work in the school system, you know, we're just forward focused. And so at that time, I had a whole day planned. And so I ended up going to the emergency room, and I was told that my kidneys were failing. And so I was devastated. I'm like, you know, I called my husband and I said, you know, they're telling me my kidneys are failing and I have to stay here at the hospital. And he's like, what? You know, I was a nursing mom, so we're trying to figure all this out. Like, they told me I had to stop. Everything stopped pretty much that day. Like, it was, you're not going to be able to nurse anymore. We're putting you on prednisone. We have to figure out what's going on. And so I could talk all day about my story, but fast forward to 2012, they were able to keep my kidneys at bay with medication until 2012, when I landed on dialysis. And the day I walked into a dialysis facility, here I was, a young mother. My daughter was 6 at the time, in my 30s. I couldn't believe it. There was a myriad of emotions that I felt when I walked in there. One, I was disappointed that I didn't know more about dialysis, that I didn't know more about kidney disease. I didn't have a family history. I didn't have the markers of high blood pressure and diabetes. No one in my family had that. So this was a complete shock to all of us. And it really took a village approach to approach what life was going to look like for me from there. I was diagnosed with focal segmental glomerulosclerosis. And so it's where portions of your filters in your kidneys become scarred. As a result of that, I would sit in the dialysis chair and I couldn't believe what I saw. As you can imagine, you experience a lot of different emotions, even from coming in some days and the chair is empty for someone that you knew sat there. And so it's like, okay, did they get a kidney or did they pass away? So all of those emotions go on while you're sitting there. But I vowed as a result of my journey that, God forbid, if anyone in my family ended up in a dialysis chair, I was going to be in a position to help them. I was going to be in a position to raise awareness about kidney disease, especially rare kidney diseases. And from there, I decided to start Kindness for Kidneys. Fast forward to 2013, I did hemodialysis as well as peritoneal dialysis. I was still working full time. We were on my insurance at the time, so it was just ideal to stay that way. But my employers were very understanding that I needed to leave to go to treatment. 2013, my sister was my donor. And I received a kidney, a perfect match from her, December of 2013. She herself has a whole story to tell and how she came to be my donor. She was probably the least likely in my family to be considered the donor, but she was the hero in my story. And so from that, I vowed through Kindness for Kidneys that we would be a source of education, encouragement, and empowerment for people who are dealing with kidney disease. And so I know I'm probably past my 3 minutes, but we do that through our virtual support groups. We have an education program, and we also do holiday caroling at local dialysis facilities each year.
Thank you so much. We need more of those heroes. I love that. So Reverend Miles, can you tell us about your role?
Sure. I guess I'm wearing 2 hats on today. Reverend Leroy. It says Leo. Leroy Jr. So my father, daddy issues. But Reverend Leroy Miles, and from Philadelphia. And so I guess I represent the collaboration. We talk about community often. So I'm representing both NMQF as well as our church, Enon Tabernacle Baptist Church in Philadelphia. And for us, I'm newer to the kidney space, but not new to collaborations, not new to community engagement. So years ago, we were talking about health disparities, and we began to do these screening events primarily for men, Black and brown men in our community. And it grew over time. So we're now seeing about 1,000 men a year. and they would come and receive a wonderful metabolic screening, a panel for the day, along with a PSA and some other innovative types of screenings. And so as time went on, men began to use it as their annual. So, brothers, we have annuals as well. And so men would just know that, especially for a PSA, it was over 40, haven't had a PSA in the past year. So our event was annual, so they would show up. But it was those years ago that we found that the church really played a role. Now, I am a Black preacher, and I love worship, fervent worship, just like anybody else. Amen. Amen. But I have been quoted as saying, I'd rather see a sermon than hear one any day. And so we find our role as church to be that, to stand in this space, to be the trusted messenger. And we just find that the men's event as the grandfather, the granddaddy event, if you will, and it's carried over to women and then, of course, other types of relationships. But we find ourselves to be that trusted messenger. We find ourselves as an entity that sits in a space. And so as a church, we're not preaching or proselytizing. Really, we're trying to create a space just for men to come. It's an 8 to 8 event, so it's a full day. When we talk about the barbershop and the dominoes and anything that a man might do on a Saturday, we would recreate that for him on that day. And so men would come and spend time with us. But in addition to those types of accoutrements, they would also receive the screenings. They would also receive health information. And just every year, it's not lost on us how lives have been saved. Families have been positively impacted by the information that has been shared at our event. So that's the space that we live in, and looking forward to engaging in the conversation.
Excellent. Well, we know faith without work is dead. And so I want to hear a little bit more, Dr. Johnson, about your work.
Sure. Thank you. Can you guys hear me? Okay, good. Thank you. Thank you so much for allowing me to be here. I'm really pleased. I've learned a lot today, and I'm really excited to be part of this panel. My name is Stacey Johnson, and I am a nephrologist. I work as an associate medical director in clinical development at Vertex Pharmaceuticals. Vertex is a biotech company that's based in Boston, and our mission is to focus on rare diseases and develop transformative therapies. To that end, Vertex has developed therapies and is working on therapies in several diseases, including cystic fibrosis, sickle cell disease, beta thalassemia, type 1 diabetes, and chronic kidney disease. And I'm really excited to be here because one of the key areas and that's really important for us at Vertex is to talk about and raise awareness about a genetic rare kidney disease that almost exclusively affects people of African ancestry. And by that, I mean people who identify as African American, Afro-Caribbean, Latino. It's called APOL1 mediated kidney disease. And it is a condition that affects about 100,000 people in the United States. But it is a condition that is characterized by an aggressive and progressive kidney failure, leading to much higher rates of dialysis and transplant. And we'll talk more about all of that, but that's sort of my story. Before I joined Vertex about a year ago, and before that, I practiced nephrology for 10 years, primarily in the South, in North Carolina and in Memphis. And so I saw exactly what Sharon was talking about, and it was always so striking to me and always very heartbreaking to me because of the toll that dialysis and kidney failure takes on people and young people in the prime of their life. And we always want to have, obviously transplant is always the goal, but sometimes we just don't have the organs. And so, as you said, sometimes you walk into the dialysis unit and you see an empty chair and you know what happened. And so I think this is a really important topic, raising awareness for kidney disease, because I think it can make a really big difference.
Thank you so much, Dr. Johnson. We're going to take a step back and have you first define for us rare kidney disease. And also, if you can talk a little bit more about genetic kidney disease and the disparities that you're working to address.
Sure. So actually, I'll even go one step back. So what is kidney disease? What is chronic? So what we're talking about here today is chronic kidney disease. And what that means is it's a functional decrease in a loss of kidney function that's persistent for at least 3 months. And the way that that's detected is sometimes through urine tests. So people may have protein or blood in their urine. It can also be detected through blood tests where people measure something called the eGFR, or the estimated glomerular filtration rate. And there are lots of cutoffs that tell you what stage you're in, but essentially to really analyze your kidney function, you need both of those tests. Urine to look for protein or blood, as well as the estimated glomerular filtration rate. Chronic kidney disease affects, I guess approximately, there's some estimates have about, somewhere around the order of 30 million people. Because it is a silent disease, and so most people don't see symptoms until they've lost a lot of kidney function. Because it's so silent, many people go undiagnosed until it's too late, often to make to reverse the damage. When it comes to rare kidney disease, there are several. In terms of rare kidney disease, and FSGS is one of them. And in terms of a rare kidney disease that disproportionately and predominantly affects the minority community, the Black community, Latino community, APOL1-mediated kidney disease fits that bill. And what is APOL1-mediated kidney disease? So it turns out that there's a gene, all of us have it, called apolipoprotein L1 or APOL1. And there are a couple changes in the gene that happen in order to actually give us some protection against African sleeping sickness. So these variants or changes in the APOL1 gene actually came about in Central and Western Africa, where sleeping sickness was endemic or is endemic. And so those genes are protective in that setting because it actually helps people protect themselves against sleeping sickness and they don't get infected. Because of the slave trade and voluntary migration, when the movement of people out of Central and Sub-Saharan Africa happened, those genes they came with us, right? And so now we don't have sleeping sickness. So we're not really needing that protection, but we still, about 14 out of every 100 African Americans will carry these variants. And depending on where you are in the diaspora, the percentage may be even maybe a little bit lower, for example, in Latin America and the Caribbean, but it could even be higher if you go to West Africa, like Ghana and Nigeria. But what happens is, in response to what we call a second hit, so maybe an infection like COVID-19, like HIV, or inflammation of some kind, sometimes even something like a stress like high blood pressure, the variant form of APOL1 can damage the main filtration system of the kidney. People start leaking protein in their urine. When you start leaking protein in your urine, one of the signs of that could be foamy urine. You can have swelling in your legs because of changes in the way fluid is balanced in the body. And you progress to kidney failure. Right now, our treatments for APOL1-mediated kidney disease are things like steroids, blood pressure medications to help control blood pressure, maybe even what we call water pills or diuretics to help address fluid. But none of that actually affects the underlying cause of the disease, right? Which is the defective or the damaging APOL1 protein. What I should say is the sort of toxic protein. And at Vertex, using some of the science that was actually really only first characterized since 2010, but using the scientific knowledge, Vertex has been working to develop therapies for APOL1-mediated kidney disease. And so when we talk about genetic kidney disease, rare kidney disease, the push, I think, around within the biotech and pharmaceutical industry has been to try to target the underlying cause rather than just address the symptom.
Thank you. And we know that's such a big difference for quality of life as well.
Absolutely.
But when we think about life and quality of life, I know that Reverend Miles, you are working in community as that village and that trusted voice. Can you share more about your local initiative and who you're partnering to get that work done?
Yeah. Screenings make such a big difference in all of our lives. And we understand as a result of COVID, a lot of the routine types of screenings are at a deficit, and which equates to another pandemic or a health crisis within a crisis, if you will. And so for us, we were excited. We've known about it. So we used to do the urinalysis, and then, you get clever and you just with the blood draw and with different relationships, we were doing a basic blood draw with LabCorp. Fine, just like you would go to your physician and they would order for you to go and get screenings or a panel done. We kept saying to LabCorp, look, we understand our folks. You can't just tell them to go. We have to continue to do what we have done, which is turn our entire church into a hospital. So, no, you bring LabCorp to us. And that's worked out significantly well. But it was just very recent that NMQF brought to our attention just how prevalent this APL01 was and how significant it would be to have both a screening event along with partnering and pairing and onboarding of clinical trials. And so for us as a church, it's not new to us. We're trying to live in that space of clinical trials. We understand that's the next obvious direction in terms of relationships. So we're not afraid of science. We're not afraid of pharma. We're not afraid of biotech companies. As a matter of fact, we appreciate the work and we understand the outcomes are improved as a result of participation. And so we kind of put our heads together. The first offering was an educational experience with our senior fellowship. So senior fellowship, the seniors come on a Wednesday and they kind of plan their trips to Atlantic City and kind of do what they do. But not our seniors. They're at another level. And there are 300 of them that meet regularly.
Oh, my.
And so what we've begun to do is expose our seniors to organizations like NMQF. So NMQF came, did a wonderful presentation to 300 seniors. We thought it was important. Of course, we'll figure out another experience for caregivers. But we have the significant men's event that happens annually, just happens to be this Saturday. My emails are blowing up. A lot's happening as we're sitting here preparing for 1,000 men to come and get screenings on Saturday. But we're going back to, we will still use the relationship with LabCorp. We'll still do the blood draw. Our nurses will do all of the preliminary, the glucose, the cholesterol, the blood pressure. And if you have an adverse reaction, we send you to LabCorp, fine. But for every man that comes on Saturday, and this happens to be just for our men's event, we converted a larger women's bathroom into, exactly, a urinalysis center, working with medical students from Pennsylvania University near us. And they're going to spend the day on rotation in that bathroom doing urinalysis. It is what it is.
Yeah.
It's going to be what it's going to be. But because of our past experiences, we have a gentleman who's near to us. And when we worked with Keep Foundation in Philadelphia, urinalysis, protein in the urine, found out, went through. He's very healthy now. We're super excited. He's kind of our advocate, if you will. But we're going back to, and we're preparing for, thank you. Thank you. So that's the event. And for my hip hop folks in the room, Freeway is a Philadelphia rapper, had that song Duffel Bag Boy with Lil Wayne some years ago that all the fighters would come out to. He's that guy, but he is actually a transplant survivor, and he'll be with us for the day. And what we, as a church, we understand our demographic, but working with Freeway and the messaging that he has, he reaches a different demographic. So we expect to have not just our usual suspects, but we're hoping to get a younger demographic. And we're also, with having Freeway kind of market for us and use his socials to get the word out, have a demographic of younger men to come and get screened on that day. So we're super excited. We're prepared. Should be a blessed day.
Amazing. Reaching people where they are. Right. So if you're in Philadelphia, hopefully they'll be able to find out more about this. Ms. Rouse, can you share more about the work that you're doing in education and awareness, but also how you're working to revolutionize the care continuum?
Yes. So as someone that has experienced it myself, again, when I walked into the facility, I was disappointed that we aren't having conversations in our community. Of course, most of the people in the dialysis facility look like me. Mm-hmm. So I'm thinking, well, why aren't we talking about this? If this is going on and it's repeating generation after generation, why aren't we having conversations? Now, granted, in most communities of color, we don't sit around and talk about our ailment. Mm-hmm. we understand. You deal with it and you do what you have to do and you just survive. You're in survival mode. And so what we've done is created spaces to hold conversation. And so our support groups, we actually started it here in the Maryland area. And our idea was to impact the southern region of the state because most of the resources were here in DC. And the likelihood of someone getting off of work and driving into DC for a support group was very slim. I know I wasn't going to do that. So we started support groups. We started on March 8th of 2020. And as you can imagine, you know what happened the following week. So we're like, okay, we had a great turnout. It was awesome. A lot of kidney warriors came out to the event and we had to shift. We had to pivot and think of something else that we were going to do. And so we transitioned to having it online. And that has really been a blessing in disguise because we have people that join our support group meetings from all over the United States. And even recently, we just had someone join us from a different country. And so what we've been doing is providing a safe space for people to come and get information, but also feel at home with people that are going through the same thing that we're all going through. It's a space of empowerment. It's not like a typical AA meeting where we're like, hey, I'm Sharon, I have kidney disease. We don't allow that. I'm like, this is not the group for that. Because we want you to leave with information and empowerment. And I always tell our kidney warriors, I should not be out advocating you. You know, this is your body. And so it's about us taking ownership of where we are, how we got there, and putting the steps in place with our village to help us get to the next level. And so it's a place that they come for empowerment and to learn more about what's going on. And we tell our warriors that you can't advocate for yourself if you don't have the information. So it's not about telling your doctor, I'm not going to do this, I'm not going to do that. And you have no rationale. You don't understand what's going on in your body. And so it's really a space to come for education. One of our signature events is our holiday drive. And so for me, it was important for me to go back to my facility where I had dialysis and see my kidney warrior peeps and the people that took care of me during one of the most difficult times of my life. And so we started out with just my facility. I said, hey, you know, let's have a community event. I just want to go back and say thank you to those that helped care for me, but also empower and encourage the warriors that are still left in the chair. And so we came together, the community donated all kinds of things, blankets, neck pillows, things that most dialysis warriors like to take with them into the facility, word puzzles, Sudoku puzzles, you name it. We were gathering it and we made bags. And we took it and passed them out to the kidney warriors as they were coming in and out of the facility. Of course, we partnered with different big organizations as well to stick information in there. My story was in there and basically just telling them to hold on. Like, this is a chapter in your story. This is not the end of your story. Don't give up. And so it ended up, you know, we ended up being on the news for it. And so now we're up to 9 facilities, including Children's Hospital. We haven't been able to go back to Christmas Carol yet, but we want to do that because I remember what it was like to sit in a chair, in a dialysis chair, and the holidays are already a time of reflection. So to sit there and think about your life while you're connected to a machine, watching your blood go in and out of your body, that just hits a little different around the holiday time. And so it was important for us to go back to say, don't give up. Don't let this be the end of your story. There's resources out here. You have a village out here that's here to support you. And so now we have expanded to doing that. Each year we add on a different dialysis facility. And it's really been a huge blessing for our community because it's needed. And like I said, we don't talk about it enough. So doing initiatives like that and like your church is doing, it really kind of eases the burden of someone having to explain to their loved one what's going on. We have resources. We have other people like myself that are okay with talking about it. My sister, same thing, sharing her story from the donor perspective and dispelling the myths that are out there in our community about organ donation. And so our recent initiative, we received a grant through Prince George's County to launch an education program. that was another area that I felt like there were a lot of resources out there, but something is getting lost between the education and the application. So we have these things, and organizations are saying, no, we have all these resources and we have these pamphlets and you just do this, do that. Well, then I'm talking to kidney warriors and say, I have no clue what they're talking about. Like, I don't know how this applies to me in my situation. When I'm leaving my facility, I'm going out, there's a Dollar Tree. I think someone mentioned this earlier. A Dollar Tree, a carry out, like, what am I supposed to do? And so through our education program, we're connecting the community, because I feel like kidney disease is not just a Kindness for Kidneys or Travere, or, it's a community approach. We all have to take ownership of it. So even the carry out on the corner, they have to take ownership too. So how can we work together? Maybe you put another item on your menu that says kidney friendly, because they're going to most likely go there anyway. So it's about how are we connecting with the community to see change in the kidney space. And so our education program, it's a 5-week interactive program. Right now we're doing it virtually, but we do cooking demonstrations. It was important to show individuals how to shop at the grocery store. So, okay, there's a Dollar General there, but here's how you can take some non-perishable food items and make it a little more kidney friendly for you. So that may be rinsing them really well, or, and just teaching them how to navigate through the grocery store. That's an important area that most people don't know. And so we call in guest speakers to help with that. And it's really, we just started, we're on our second cohort, and it's really been a blessing. One of the things that we really wanted to incorporate were the caregivers. And I've heard that as a common theme today. We often neglect our caregivers, but I also look at the caregivers as that's another resource there who has a circle of influence as well. And many times in many of our support group meetings, we have caregivers, and I've never even met the patient that they're caring for. They just want the information because they feel helpless. Like, I'm here to support my loved one, but I have no idea how to do it. I don't know what he or she can eat. I had a husband that called, and he's crying, and he's like, all I know is I drop my wife off to this facility every day, and I have no idea how to support her. And so it was important for us to include them. So each patient can bring 2 caregivers with them to the sessions. And we provide whatever resources the patients are getting, so are the caregivers. So if it's the food items, if it's, we give them books and things like that. And so we've seen great success with that, and we want to continue expanding it. We're limited to a certain catchment area with this particular grant, but we're hoping to be able to expand it. And we call in kidney warriors that have gone through it. The chef that runs the nutrition class, she's a 2-time kidney transplant recipient herself. So having peers connecting with other peers, we find that it's been more beneficial for our kidney warriors. And so we're just getting started. We're 4 years in the game, and so we're hoping to do a lot more to raise awareness.
Well, it sounds like your impact's been tremendous. So, Ms. Paris, we're going to have you answer a question in a moment. I'm just going to open up. If you do have questions, we're going to take questions from the audience and start Q&A after Ms. Paris's next question. So I know that you're also working on an unknown causes project. Can you share more about that, and then also the work that American Kidney Fund is doing for patients and policymakers and provider engagement?
Sure. So I'll start by saying, we call ourselves at American Kidney Fund a 360-degree organization, because we recognize that there are so many components in being able to make progress against kidney disease. So that 360 includes policy, it includes education, it includes engagement with professionals, it includes creating materials that people can actually use. And so we look at it a very kind of multi-pronged kind of approach. So I wanted to say that first, because that really leads in how we began the Unknown Causes of Kidney Disease project. So American Kidney Fund, we financially support about 1 in 7 people who are on dialysis in the country. So we have a pretty robust database of people that we've helped over the years. And we survey this population occasionally. And one of the things that we ask, and this is all self-report, what was the cause for kidney disease? And we had, of course, a lot of people say diabetes. That's the #1 cause of chronic kidney disease. And then we had a group of people who had high blood pressure. There was a component of people who had a rare disease, that they were able to identify polycystic kidney disease. But there was a way too high percentage of people who did not know the cause of their kidney disease. Now, there might be some recall bias, I'll say that because some people, there's so much information that you're getting because a lot of people, just like Sharon, had no idea that they had kidney disease, crash into dialysis and emergency room and are told, you need to go on dialysis. And nobody thinks about a lot of things there in that moment. So we wanted to find out, do people really not know the cause of their kidney disease? Why do they not know? Are they not being fully diagnosed? Is there a lack of communication? Do people not know that they have a rare form of kidney disease? So as part of this multi-component effort, we wanted to bring in people in the kidney community, and that included patients or people living with kidney disease, caregivers, that included people who led organizations, government officials when we could, and also industry. And through that, we wanted to find out, combined with another survey that we did with primary care physicians, nephrologists, we wanted to get down to understanding more and helping people advocate for themselves to understand that it's important to know what caused your kidney disease. So through a series of focus groups, we were able to extract some of those bigger issues and barriers to people not knowing the cause of their kidney disease and being diagnosed. We say too late, just like Dr. Johnson, it's, you have no opportunity to do anything to stop the progression. We wanted people to know earlier when they could. So as a result of that, there's been an implementation plan that we're calling our roadmap to be able to work with people in the community to make progress in the rare disease space. So we are going to begin, we don't have a title for it yet, but it's our rare disease portal. Well, there'll be a lot of resources for people who are diagnosed with rare forms of kidney disease and tools that we put together and how to have those conversations with your doctor, but also to know what answers to look for and what you can do about it. Because it's one thing to be able to have a list of questions to ask, but if you don't know the answer you should get, you don't know how to respond to something, that's a whole different thing. So we're looking at it from multiple angles to see how we can best meet the needs of people who are living with kidney disease and also working with providers. We have to work with everyone. And we also have a lot of different resources that we put together. People who have to eat with kidney disease. We have our kidney kitchen. It's all about eating with kidney disease. That's good. And, also a lot of ways that people can help in their way. They don't have to be a professional in the renal space. Luckily, and thank you very much, Sharon is one of our ambassadors for American Kidney Fund. And we appreciate the efforts of people who are going out there and sharing their word about kidney disease, policies that need to happen to make lives better for people who serve and live with kidney disease. So with the unknown causes, we hope to be able to keep those groups together so that we can continue to fight for kidney disease, to help people understand that it's really important and people have a right to know what caused their kidney disease. Absolutely. So through that effort, which we hope will continue, it's just been really enlightening to work with people and really understand the impact of knowing what caused your kidney disease can have on your treatment and how you move forward in life.
Thank you. I think we have two questions, so we're going to start over here. If you'd like to ask your question.
Sure. Teresa Rohr, Kurtzgraber. I'm an internal medicine physician doing primary care, and I'm here on behalf of the AMA Minority Affairs section. In primary care, we love prevention. We love prevention. However, if I don't have a diagnosis code to use for screening, I'm stuck. So if I'm seeing an adult who's otherwise healthy, but I understand that there is a need to screen for renal disease, for kidney disease, what code do you use to make this work so that it can be covered?
That's a very good question. There really is, you're absolutely correct. There really is no code. And currently the U.S. Preventative Services Task Force, in terms of screening for kidney disease, a lot of the focus is currently on diabetes, right? So you have diabetes. Most people with diabetes will have some assessment of their kidney function, both with urine and blood. That task force actually, through efforts of NKF and the National Kidney Foundation, the American Society of Nephrology, has been asked to look again at the evidence to support screening for kidney disease in patients with high blood pressure. Mm-hmm. So currently, that's not one of the recommended tests that's done. But when we look at something like APOL1 mediated kidney disease, which in adults often presents as what a lot of people get that blanket term, hypertensive kidney disease. And it actually, what we may be missing is that there's a genetic cause there that we may be ascribing to and saying it's because of hypertension, but you have somebody who's well controlled on medications and doing everything they can do. So you're right. Currently, in an otherwise healthy person, we really don't have a diagnosis code that you can attach so that the patient doesn't have to pay out of pocket. But if you have someone who maybe they have high blood pressure, and you measure their kidney function and their eGFR is 90, my challenge is, okay, but maybe we need to check the urine and make sure there's no protein in the urine, because those two things can be separate. And in fact, protein in the urine with what we consider to be very well preserved kidney function can be a sign of underlying kidney disease. Melanie brought up kidney disease of not unknown, kidney disease of CKD of unknown origin, essentially, or not knowing why they're caused. One of the things that many nephrologists and experts in the field will say is like, if you have an African-American patient or Afro-Latina, somebody with African ancestry, and they have kidney disease and you don't know why, maybe get a genetic test and look for APOL1. And often that is the case. About 4 out of 10 African-American patients on dialysis have APOL1 mediated kidney disease that was just not diagnosed.
Thank you. It sounds like there's also some policy opportunities there as well.
Yeah.
We'll take the question on this side.
Hi, I'm Heidi Waters, Senior Director of Policy Research for Otsuka Pharmaceuticals. Along those policy lines, some of the things we've noticed in our company is that a lot of the quality metrics that are aimed at kidney disease are aimed at dialysis and improving dialysis. There are no quality metrics for being able to screen and diagnose patients early to get them the care they need earlier before they go to dialysis. So is the American Kidney Fund or anybody else working on efforts to sort of back that up and get quality metrics in play so that we can screen earlier, detect earlier, and prevent some of the downstream consequences?
So I'll start. So because our government affairs people could not be here, I can conveniently refer you to our government affairs people. I work in partnership development and also in kidney disease education. But I can tell you that the government affairs department at American Kidney Fund work night and day to support not just supporting people who are on dialysis, but we are very committed to prevention. We don't want people to have to apply for our financial assistance programs because they're on dialysis. We want people to know about the latest treatments that are available, and there are things that can sometimes be done to slow down the progression of kidney disease, and in some cases prevent it altogether. So we can talk after, and I'd be happy to give you the information of our government affairs area.
And just real quickly, again, I'm newer to the space, but I'm on all of the calls. And it was interesting to hear this conversation with NEFCURE and LabCorp talking about getting a grant or figuring out a way to make sure that our participants at the event did not have to pay anything. And for us, we don't ask for insurance. It's never an issue. We treat this, everyone's just kind of treated the same. We just kind of we just don't ask the question. And there's never a conversation around cost and or a card. And I appreciate the dialogue between the two because they're compete. at one point competing interests, but for the sake of the screening and for the sake of the community engagement, we're willing to come together to underwrite the cost for the men on next Saturday. So for me, that was huge, and it does speak to early detection, and it speaks to being preventative in nature. So it's about being creative and putting interests aside for the greater good.
We'll take the question over here.
Thank you, Jonah Odom, NIH. I want to thank Dr. Johnson for what I thought was an excellent summary about APOL1 and its impact in the Black population. I have one comment and a question. The comment has to do with the fact that we even see it in transplantation, where deceased donors, Black donors with this APOL1 variant, G1 and G2, in the recipients of these donor kidneys. Those kidneys don't last long, at least based on retrospective studies. And the NIH is conducting a huge national study to answer this question, where we have matched over now 5,000 Black brain dead donors with kidneys to their recipients to answer first and foremost, what is the driver in the outcome of kidney transplantation in Blacks? Now, the question I have for you, Dr. Johnson, is I don't know where your product is in the development in terms of phase 2 or 3, what the safety and efficacy data are showing. But what is Vertex doing, assuming you're successful with your investigational agent, in terms of pricing and for the desired population to have access to this product if it's successful? You yourself have stated that it affects people of African origin all across the globe. And so I would think that companies like yours are thinking about the whole issue of access and how it will be priced. Thank you.
So first, to your comment, I agree. You're exactly right about the impact on transplantation, and I'm really looking forward to the results of that study to see how what we learn. So the product that Vertex is currently in the phase 2-3 stage, and so for those there is a clinical trial now that's in the phase 2-3 stage. So we're still trying to work and understand and investigate the effectiveness and the safety. So I don't have any additional information on that front. With respect to what the company is doing to ensure access, should the product be proved to be safe and effective, in clinical development, I can't tell you exactly what that is because I'm not part of those conversations. But I do know that that's something that the leadership at Vertex is thinking about, because you're exactly right. This actually is something that affects not just people in the United States, but across the diaspora. So I'm sorry, I don't have the additional information for you, but hopefully as we go further in the process, we'll be able to give you more information.
Thank you. We'll take the question over.
Hi, I'm Andrea with Quality Insights, ESRD Network 5. So I have both an offer for you, Sharon, and a question. I'm just now hearing about this 5-week, program that you're putting together. And so I want to put out the offer that at ESRD Network 5, we're able to help you kind of expand your reach. I know you can only focus on one area, but we can get together and I'm sure I can help you expand your reach. Melody, you mentioned earlier that people of color, namely Black patients, are less likely to have a confirmation of their kidney disease diagnosis. That coupled with, the issue of race and EGFR and how people have not completely aborted that mission. And it leads to all sorts of delays, including delays with kidney transplant. And Sharon, you've been blessed to be able to have a living kidney donor. And I just really want to hear from you all. And I know this is a policy issue as well, but hear from you all about what can we do to really help people of color, namely, those from the Latinx community, those from the Black community? How can we help them to be able to feel really kind of embrace the a transplant? We have more education. We're really trying to push that, but it's not translating because there's a policy issue and people are afraid that they're going to lose access to their insurance, not going to be able to pay for all of the medications that they have to pay for once they get a transplant. So I'm just really interested in some of the innovative ways and the ways that we can kind of collaborate with the community to try to push those efforts towards kidney transplant.
Sure, I'll start. I am a part of the ESRD Network 5's Patient and Family Engagement Council. So Renee Bovacalis and I are very close. She's actually on the support group committee. So we will definitely be in touch to have conversations about that. It's so interesting that you asked that question because I just started doing some part-time work with DaVita. And I can't tell you the number of barriers that I see that I didn't know existed. When it came to preparing for transplantation, my role is to assist patients with getting waitlisted. And so I see both sides of it because I sat next to people that are like, I'm not going through the process again. I'm not doing it. I had a transplant, it failed, or I just see other people and they're back in here after 5 years. I'm not going through that. And so I see both sides of it. And my answer to that would just be, we have to continue to put other patients in front of them, continue to arm them with information. I don't know about the policy part of it because what I'm finding is that there are a lot of barriers there that I don't feel need to be there. And sometimes it's based on the transplant centers, guidelines and their listing criteria, and then other things that you have to jump through just to get there. And so I can see from a patient perspective, one, you're tired after dialysis. I wouldn't want to deal with it either, but you really have to have, and that's why I tell patients, you really have to out advocate for yourself. Like you have to out advocate everyone around you because at the end of the day, it's your body, it's your life, and so I think it's really taking creative approaches as well, meeting people where they are. A lot of times people don't want to hear what you have to say until you meet their needs. And so I know that even at our last ESRD Network 5 meeting, I said, well, what kind of incentives are out there to really make me want to do this? Like what, as a patient, I'm tired. I'm worried about how I'm getting back home from dialysis. I'm worried about my transportation. What incentives are in place for me to want to keep going in this process? And so I think we have to be very creative. We have to meet people where they are. And then we have to call in the community truth. It shouldn't be an ESRD Network 5 issue just by yourself. It's a community issue. And we have to keep it in front of the community so that they understand that it's a responsibility of all of us to change the narrative surrounding kidney disease, not just one organization here, one there. We have to come together to really do this and to really see impact and change. And so my advice would just be to continue to look for those creative ways to engage them. I do lobby days where I come and sit in lobbies. I know right now COVID is kind of hampered some of that, but I do go into dialysis facilities and just sit and share my story. I pass out resources. I say, hey, we have a support group, or we're planning a cooking class. If you can't make it, can your care partner make it? And a lot of times the care partners are the ones sitting in the lobby because they're waiting for their loved one to come out. So to me, that's an opportune time to take advantage of. And maybe the patient may not do it, but their care partner who's with them more than we are can help them navigate through some of the challenges. But the policy pieces, I'm seeing more and more that, it's not just the patients that don't want to do this. There's some real barriers that are there that I can see why some just shut down, as far as wanting to move forward with the transplant and tackle. Even my sister and I, it took us a year to get to the transplant table because of barriers. We kept being told no. And so we had 5 different transplant dates before we actually ended up on the table. And it got down to me writing a complaint to the hospital. Some people aren't willing to do all of that. And that's where organizations like mine come in, because I'm like, no, what do you need? You need the cover, you need the template. What do you need? This is your life. And the probability of you being, living a long life on dialysis, it lessens each year that you're on it. And so I think there are a myriad of things that need to be done to really dissolve some of those barriers, policy included.
I can speak to kind of our approach really at American Kidney Fund, and also specifically about access to transplant. So it's kind of interesting. We do surveys among our audience and our patient population fairly regularly, and we just did one. I think we got our results back maybe about a year ago, and we were asking people within our database about transplant and access to transplant, and who talked to you about a transplant. Some said nobody's ever talked to me about a transplant, but that could have been a long time ago. Who knows? But the one thing that I thought was so interesting, we were asking about being on a transplant wait list. And I cannot remember exactly what percentage, but I'm going to say maybe around 15%, I'd have to look, said that they didn't know whether or not they were even on a wait list. They didn't know. Probably. And I think it's a couple of things that the transplant process is complicated. You know, I have to read stuff all the time. Different transplant centers may have different requirements. Some people don't know that you can be on more than one wait list. Some people assume they just won't qualify, and the finances are huge barrier for people. So what we try to do at American Kidney Fund, hello? Okay, there it goes. To meet people where they are, as you said. So when we put our materials together, we make sure of a couple of things. One, we make sure to create things that are within standards of health literacy and plain language. And when we say health literacy, it has nothing to do with one's education level. This is a complex process with brand new. I'll just try to talk about. So with a lot of words, so we don't want any barrier to have a PhD in whatever, but very. So we try to materials that this is what you do, and this is the process. Working on it right now around transplant. Oh, here's back. We're working on a new toolkit around transplant, and not just in a very kind of third-party cold way, but we want to talk to people that this is complicated, this is hard. How do you not just become eligible for transplant? How do you stay eligible while you're waiting? We put workshops together for people to talk to them about how to ask for a donor. A lot of people don't want to ask for donors. They feel guilty. They don't want to ask their family. They would rather not talk about it. So, we have patient testimonies to try to help people become encouraged and be able to see themselves in what they're hearing. But, again, with transplant, it is a very complex process, and the insurance and finances just add a whole other layer to that.
I'd like to also add to it that, as providers, providers also have a responsibility as well. I always tried, if I could, to get the patient referred in time for potentially a preemptive transplant, right? Because as we talked about, your lifespan on dialysis shortens the longer you stay on dialysis. So the best option is to not go on dialysis at all. But sometimes if that doesn't work, then you talk to the patient, you say, hey, I want you to go ahead and we're going to make this appointment. So I always try to, sometimes we as providers, there's so many patients to see, we may forget those little things like, did this person get a referral to transplant? Because actually that's when somebody starts dialysis, there's actually a form you have to fill out that lists, their health issues, why they're on dialysis. And there's actually a question that says, does this patient know about their transplant option? And so the government is trying to force us to talk to people, but sometimes we get caught up in all the things that we have to do. So addressing, when you have a patient who may be hesitant, maybe spending a little bit of extra time with that patient and saying, okay, tell me what are your concerns about transplant? Answering questions about the immunosuppression and letting them know they can be listed at multiple places as long as those transplant centers are not competing for the same organs, they can be listed at multiple places. And I've had patients listed at 4 or 5 different transplant centers. So it is possible. So patients can educate themselves. But then also, I don't want to say that we as providers don't have a role. We do. Yeah, we do.
Certainly. We're going to take this last question and then we're going to wrap up.
Thank you.
Thank you for patiently waiting.
No problem. Alta V. Ewing, Genentech, Global Health Equity and Population Science. And I'm also trained as a genetic counselor. So Dr. Johnson, you've been speaking my language the entire time. I am also an APOL1 variant carrier, and I have an extremely strong family history of chronic kidney disease. So my question for the panelists is, do you commonly work with genetic counselors and specifically genetic counselors of color? And then also, Dr. Johnson, if you can speak more so to the genetic testing landscape in terms of availability of genetic tests for APOL1 variant. And part of the reason behind the question is because I actually consulted on a research project that claimed to want to diversify did not disclose APOL1 status. And it was not until I reached out to the principal investigator and highlighted that this is a missed opportunity to provide important genetic information to a population that's disproportionately impacted by a disease, that the information was finally brought to the laboratory's attention and finally addressed. But I'm just wondering if that's the norm across the genetic testing landscape. And again, if you all work closely with genetic counselors of color.
Thank you.
So I can start about, so there are currently in the kidney disease space, there's a couple panels that are available. One done by a company called Natera, and I think there was another one done by Renasight. I'm not sure. Natera may be more familiar to people in the room. They offer a panel of genetic tests. So you don't just get one, you get a lot. And for sometimes for nephrologists, that may be a little bit overwhelming because then they have to explain what each of those lines means. The coverage for genetic testing varies depending on where you are and what the patient's insurance status is. And so a lot of providers may also say, because we don't have a targeted therapy for APOL1 mediated kidney disease, it's knowing the genetic result is not going to change my management. I would argue that knowing the genetic result could help empower a patient and also help them have discussions, important discussions with their family. So I would be in favor of having that information. So the landscape is varied. There are some places, usually large academic centers, where the testing is very routine, but then you go out into the community and it's not the same. That's number one. As far as genetic counselors of color, that's a very good question. I know we work with genetic counselors. I actually have to say I do not know what their diversity and what their workforce looks like. And that's something that I'm going to take back to the company and ask about, because you're right. That's something we need to think about, because when people receive information, sometimes having that connection with somebody who looks like them or maybe even has family members who's gone through the same thing may help. I know that we know that to be true. And then you asked the third question. I can't remember the third one.
Well, you really answered both in terms of working with genetic counselors of color and then the genetic testing landscape.
Yeah.
And I can actually help you with the workforce question because I was on the board of directors for genetic counselors. So 2% of genetic counselors identify as genetic counselors of African descent. And 10% of us identify as genetic counselors of color. So there are not a lot of us. However, if you're interested in getting plugged into a group of minority genetic counselors, I can definitely help with that. And last thing that I wanted to mention, there is a bill that will be reintroduced in the House and the Senate this year. It's called the Access to Genetic Counselor Services Act, and that will help really increase access to genetic counselors, access to genetic testing, to ensure that more payers are actually covering genetic testing or reimbursing for it. So I do ask for your support in that. Thank you.
Absolutely.
Thank you. Well, we are going to end on that note. I thank you all, especially our panelists, for helping us to reimagine kidney care and treatment, and also each of you for what you also brought to the conversation today. Thank you.
Thank you.